Hello, I am Raj Kimono, Assistant Professor of Medicine at McMaster University, and this is Kim Legault. Kim is a rheumatology fellow here at McMaster. Over the next few minutes, we will demonstrate examination of the shoulder. Remember that shoulder pain can arise from any of the joints or soft tissue structures of the shoulder complex. Shoulder pain can also be referred from the cervical spine. Depending on the clinical presentation, you may need to examine the cervical spine and perform a neurological examination of the upper limb. You may need to also examine the joint below, in this case the elbow. Our demonstration will be structured into inspection, palpation, range of movement, power assessment, and special tests. You should examine and compare both sides. However, for the purposes of this video, we will focus only on the right shoulder itself. Before we go into the examination, we will first demonstrate some surface anatomy. The shoulder complex is made up of 4 articulations. The sternum articulates with the clavicle, forming the sternoclavicular joint. The clavicle articulates with the acromion process of the scapula, forming the acromioclavicular joint. The humerus articulates with the glenoid cavity of the scapula, forming the glenohumeral joint. And the scapula articulates with the chest wall, forming the scapulothoracic articulation. This is not a true joint. Now, because the glenoid fossa is small and shallow, the glenohumeral joint is inherently unstable. There are 2 types of stabilizers, static and dynamic. Static stabilizers include the glenoid fossa itself, the glenoid labrum, which is a ring of fibrocartilage around the fossa, the negative intra-articular pressure, the joint capsule, and the ligaments around the joint. Dynamic stabilizers are made up of 2 layers of muscles. The outer layer, which are the main movers of the shoulder, include the trapezium, which is demonstrated here, as well as other muscles which we have not demonstrated on Kim's shoulder. These include the deltoid, the pectoralis major, as well as the latissimus dorsi and teres major. The inner layer of dynamic stabilizers are responsible for stability and movement and consist of the long head of the biceps tendon, as well as the rotator cuff muscles. The rotator cuff muscles are made up of the supraspinatus, which arises in the supraspinatus fossa and dips under the acromion to attach to the greater tuberosity of the humerus and is responsible for abduction. The infraspinatus muscle arises in the infraspinatus fossa and attaches to the greater tuberosity of the humerus and is thus responsible for external rotation. The teres minor attaches on the axillary border of the scapula and attaches to the greater tuberosity of the humerus and is also responsible for external rotation. The subscapularis, which is not demonstrated here, arises from the anterior part of the scapula and courses around in front of the humerus to attach to the lesser tuberosity and is thus responsible for internal rotation. For inspection, look at the shoulder from the front, the side, and the back, and remember to compare both sides. Look for swelling, particularly at the joints, the sternoclavicular, acromioclavicular, and the glenohumeral joint. It is not usual to see swelling here, but in cases of large effusions, the deltopectoral groove may be lost and a bulge may appear in this location. Also, make note of any scars or erythema. Look as well for any atrophy of the muscles, the pectoralis major, the deltoid muscle. Wasting of the deltoid muscle causes squaring of the shoulder because of loss of the rounded bulk of the muscle. Also, look at the supraspinatus muscle for wasting and the infraspinatus, as well as the trapezius muscle. Take note as well of any deformity. Stub deformity of the clavicle may suggest a prior fracture, while stub deformity at the acromioclavicular joint may suggest disruption of the AC ligament. And remember to compare both sides for symmetry. Look at the height of the shoulders. If one shoulder is higher, this can be due to scoliosis or a Sprengel deformity, which is a congenitally small and high-riding scapula. To finish off, look for winging of the scapula. I would ask Kim to do a push-up against the wall. Protrusion or winging of the scapula suggests injury of the long thoracic nerve and paralysis of the serratus anterior muscle. Palpate the soft tissues, bones, and joints for warmth, tenderness, and swelling. For example, start medially, feeling the sternoclavicular joint, the clavicle, the coracoid process, and the acromioclavicular joint. Also, palpate the long head of the biceps tendon. Tenderness here suggests bicipital tendinitis. The tendon will be felt as a cord on the anterior aspect of the shoulder. If you have difficulty locating it, place your fingers on the anterior aspect of the shoulder while rotating the arm, and the tendon should slip under your fingers. The short head of the biceps tendon is located just medial to this. Check for tenderness at the rotator cuff insertion on the greater tuberosity. You can expose this by extending the arm and bringing the humerus out from under the acromion and palpating. Also, palpate the muscles for bulk and tenderness, including the deltoid muscle, the supraspinatus, infraspinatus, and trapezius. Also, feel along the spine of the scapula for tenderness. And remember to check for crepitus. You can do this by placing your hand over the shoulder while moving the arm. You can also place your hand over each of the joints during shoulder movement to try to locate the exact source of crepitus. Let us move on to active range of movement. It is easiest to demonstrate and have the patient follow you. Get the patient to abduct the arms. Normal abduction is 180 degrees. Then have the patient adduct the arms. During abduction, look for a painful arc, which usually occurs between 60 and 120 degrees. This suggests subacromial impingement and usually improves beyond 120 degrees. If pain begins after 120, this may be due to problems with the acromioclavicular joint. During adduction, look for a positive drop arm test. This indicates complete tear of the supraspinatus tendon. From the side, assess flexion. Normal flexion is about 180 degrees. Then assess extension. Normal extension is 60 degrees. With the arm abducted to 90 degrees and the elbow flexed at 90, assess external rotation and internal rotation. Normal is about 90 degrees in both directions. You can also test rotation with the elbows at the sides. External rotation is about 45 to 90 degrees in this position, and internal rotation can go up to 120 degrees. You can ask the patient to touch the tip of the opposite scapula. This is also known as Apley's scratch test. Finally, look at scapulothoracic rhythm. The first 30 degrees of shoulder movement occurs mainly at the glenohumeral joint and is due to supraspinatus contraction. Beyond 30 degrees, the scapula engages with a 2-to-1 ratio of glenohumeral to scapulothoracic movement. That means, for example, for 10 degrees movement at the glenohumeral joint, the scapula would move 5 degrees. With reverse scapulothoracic movement, or reverse scapulothoracic rhythm, the patient appears to hitch the entire shoulder complex. This occurs because of decreased movement at the glenohumeral joint, as would occur in adhesive capsulitis, for example. Generally speaking, if active range of movement is normal, you may not need to do passive range of movement. However, if active is limited, then take the joint through passive range of movement, particularly in the plane of limitation. I will demonstrate these planes on Kim's shoulder. I will first assess flexion, then extension, abduction, and adduction. as well as external rotation and internal rotation. Assessing passive range of movement can help you identify the cause of limited movement. For example, in neuromuscular weakness, the patient's active range of movement is limited, but passive should be normal. Whereas in bony, ligamentous, or capsular problems at the joint, both active and passive are limited. Also, assess the end feel. A bony or firm end feel can be found in conditions such as severe osteoarthritis where bone blocks movement. A soft end feel can be found in ligamentous or capsular problems. In adhesive capsulitis, there is global restriction in all planes of movement, particularly with external rotation, where there is usually a soft end feel. Let us look at power assessment. This is best done by resisted isometric testing. Get the patient to meet your resistance rather than you trying to meet theirs. Also, use one hand to stabilize the shoulder or elbow as needed. I will first assess Kim's flexion power at the shoulder. Don't let me pull your arm back. Then extension. Don't let me push your arm forward. Then I would assess external rotation. Don't let me push your arm in. And internal rotation. Don't let me pull your arm out. For abduction and adduction, do both sides together with the arms abducted to about 20 degrees. Test abduction. Don't let me push your arms in. And adduction. Don't let me push your arms out. We would first assess for impingement. With impingement, the head of the humerus jams against the underside of the acromion process during abduction. The intervening tissues can become irritated, including the rotator cuff tendons, particularly the supraspinatus tendon causing supraspinatus tendinitis, as well as the subacromial bursa causing subacromial bursitis. We have already demonstrated a painful arc for impingement and the drop arm test for supraspinatus tear. The next test is the Nair's test. This is a passive test. Start with the arm in this position and bring the arm upwards. Remember, near, close to the ear. A positive test is pain in this position. The next test is the Hawkins test. Place the arm in this position with the shoulder and elbow at 90 degrees. Then grasp the forearm and internally rotate the shoulder. A positive test will be pain at the tip of the shoulder. If your hand is too small to grasp the patient's forearm, you can also do the test in this manner. Then press down on the forearm, producing internal rotation at the shoulder. The empty can test is another test for impingement. As the name implies, have the patient position the arm as though emptying a can. This is about 45 degrees of flexion and abduction. Then press down on the patient's arm while having them resist you. Don't let me push your arm down. A positive test would be pain at the tip of the shoulder. The principle of all these tests is to cause impingement of the humeral head against the acromion and produce pain. We will now demonstrate the lift-off test. This is a test of the subscapularis and is essentially a test of resisted internal rotation. Have the patient place the arm in this position and try to push your hand away. Kim will be unable to do this if she had a weak or torn subscapularis. We will now move on to assess for bicipital tendonitis. First, palpate for tenderness by rolling your fingers over the tendon. We have already demonstrated how to locate this tendon. You can then perform the Yergason's test. This stresses the biceps tendon by resisted supination. If you forget, place your hand over your biceps tendon and supinate and pronate your forearm. You will realize that the biceps contracts during supination. I will therefore try to pronate Kim's forearm this way while she tries to resist me by supinating. Okay. Don't let me turn your hand over. A positive test will be pain over the area of the biceps tendon. The next test for bicipital tendonitis is the speeds test. Think of your arm in the position of bowling where you want speed. We'll have Kim place her arm in this position. Don't let me push your hand down. A positive test will be pain in the area of the biceps tendon. In clinical practice, you may actually do both sides at the same time. Now, let us assess the acromioclavicular joint. We would have already palpated this joint for tenderness. To further assess the joint, you can either compress it or try to distract it. To perform AC joint compression, ask the patient to put the hand on the opposite shoulder. Then stabilize at the back and try to push in on the arm. A positive test will be pain over the area of the AC joint. We can then try to distract the joint. To do this, we'll have Kim place her arm in this position. I'll stabilize at this shoulder, again pushing on the arm this way, and trying to pull the AC joint apart. A positive test would again be pain over the AC joint. Finally, finish off with stability testing. Test for anterior or posterior instability by trying to move the head of the humerus backward and forward. You can then assess for inferior instability by pulling down on the arm. In inferior instability, a sulcus would form at the tip of the shoulder as you pull down. This is known as the sulcus sign. Testing for recurrent anterior subluxation should be done in the supine position. The first step is the apprehension test. The arm is passively abducted and externally rotated at 90 degrees with pressure applied on the humeral head in an anterior direction. I am pulling Kim's humeral head forward. In a positive test, the patient becomes apprehensive and complains of pain. The relocation test is then done by applying pressure in a posterior direction. The patient will be comforted and look relieved. The next step is the anterior release sign done by removing the posterior force. The patient would again look scared and complain of sudden pain. We hope that this video was useful to you. Remember, you may need to examine the cervical spine and perform a neurological examination of the upper limb if you suspect referred pain. You may also need to examine the elbow. I am Raj Kamona, Assistant Professor of Medicine at McMaster University, and this is Kim Legault, Rheumatology Fellow here at McMaster. Thank you.